want a second one? All right, well, I will get started. It's great to see everyone. My name is Dr. Glatts, and I'm here with Charlene Wu. Together we represent the Syngap1-RD clinic, and we will be discussing some behavioral landscape insights from standardized assessments. So as just a note, neither of us have any relevant disclosures. And here you can see, we'll start with a brief overview of today's presentation. We'll start by conceptualizing what is difficult behavior. I'd like to talk about a few different tools for assessing behavior, specifically the CBCL or Child Behavior Checklist, as well as the Vineland Adaptive Behavioral Scale. And then we'll talk about some data from our own clinic and wrap up with a few next steps. So just to make sure we're all on the same page, what is difficult behavior? Difficult behavior seems self-explanatory, but it's actually very complex. As I think of it, it is observable, outwardly directed behavior, such as severe tantrums, aggression, self-injury, or extreme noncompliance, that is happening with a high frequency and intensity, greater than expected for a child's developmental level, and it has to interfere with their functioning. So think family life, community participation, or school.
All right. So if we are talking about challenging behaviors within the context of Syngap1, oh, sure. I'll let you turn that off. Sorry about that, guys. It can include any one or all of these. So it can include high emotional reactivity, frequent irritability, tantrums and meltdowns, aggressive outbursts, self-injury, impulsivity and hyperactivity, low frustration tolerance, difficulty with transitions, and sensorily driven dysregulation, which we kind of had a conversation about earlier, which I was extremely appreciative of.
So there's not one best scale to measure behavior. Why is this? Well, behavior is so multidimensional, and it is expected to change with age. A tantrum in a 2-year-old is normal. A tantrum in a 12-year-old, probably not as normal. Behavior can also vary across settings and by different observers. It is really context dependent. And behavioral constructs are not discrete biological categories. They're rather attempts to summarize a pattern, and this can be extremely difficult in neurotypical children as well as neurodiverse children. So I mentioned there's many tools for assessing behavior. Here's just a smattering of a few of them, and these are the two we're going to focus on now. So the Child Behavior Checklist is a standardized parent reporting tool used to look at emotional, social, and behavioral functioning. There's 2 versions based on age, so a younger child version and a school age version, and it's completed by parents and caregivers. There's anywhere between 99 and 113 questions, depending on how many sections you answer, and you can see an example here. The CBCL gives a report out of syndrome scales. Think things like aggression, attention problems, sleep problems. It then gets broken down into DSM-5 oriented scales as well as broadband scales. So I'd like to go through those just briefly here. The syndrome scales vary slightly based on age. So in the preschool cohort, they will measure emotional reactivity and sleep problems. In the school-aged cohort, they will look at thought, rule-breaking, and social problems. And then for across all ages, they look at anxious and depressed, somatic complaints, withdrawn, attention problems, aggressive problems, as well as stress problems. And then those get mapped out onto the DSM-5 diagnoses. Think affective problems, which is essentially depression, anxiety, ADHD, oppositional defiance, autism, measured only in the preschool cohort, somatic and conduct problems, measured only in the school-aged cohort. It also gives you a broadband readout, so internalizing, externalizing, and total problems. So this is our data here. We looked at data from Simon's Searchlight, and here you can see T-scores for the various domains. Just to briefly orient you to the graph, the background gray dots are any individual with a neurodevelopmental disorder, and the colored dots are individuals specifically with Syngap. The blue dots fall within the normal range, the yellow dots fall within the borderline range as measured on the CBCL, and the red dots fall within the quote-unquote clinical range. And those ranges do vary slightly based on which scale is being measured. So you can see here Syngap individuals sitting above the general neurodevelopmental disorder population in the domains of attention, externalizing problems, social problems, thought, total, as well as autism. You can also see a higher burden in the clinical range for aggressive problems, internalizing problems, sleep, internalizing problems, and withdrawal. Interestingly, there were normal range scores in anxiety and depression, rule breaking, sleep, that one's only measured in the preschool cohort though, as well as somatic complaints. So here you can see the same data just with the axes reversed, which helps appreciate the age distribution. As you can see, age in months plotted along the bottom. And it appears that there's really minimal age-related trends as severity levels do not shift greatly based on age as age increases. You can see here, though, that these red dots in these two specific boxes for aggression and externalizing problems do appear to kind of start around the age of 5 and kind of persist through here, which is about the age of 12. So some takeaways from the CBCL. We find elevated behavioral and emotional symptoms compared to the broader neurodevelopmental group. We found the most challenges seem to be with attention, thought, and social problems, and oppositionality or acting out and aggression seem to peak maybe between 5 and 12. And these takeaways at this point are still speculative. We kind of need to do some further analysis to determine the significance of these takeaways. Now I'd like to shift to the Vineland.
All right, so now we're transitioning over to the Vineland, which is a measure of adaptive behavior. It is utilized for children children and grown-ups between the ages of from birth to when they're 90 years old and older. It is completed by the parent or caregiver. Multiple people probably in this room have had to fill one out. And it measures multiple domains. So there's a communication domain, a daily living skills domain, a socialization domain, and the adaptive behavior composite is the sum of those three. Motor skills and maladaptive behaviors are also other domains that are also covered by the Vineland, but those are optional to be filled. And they aren't incorporated in that adaptive behavior composite. So similarly to the graph that Carlyn just showed with the CBCL, the gray dots here also represent people with neurodevelopmental disorders, while the green dots represent our Syngapians on the Vineland. And just to orient you to what these different graphs are, the top right is the total score, so the three domains that we had talked about. The one in the top middle is communication. Daily living is the one on the top left. And then the motor skills are the bottom right, and then socialization is that middle. And as you can see, there is less variability across each of the Syngap green dots that you see here. And they tend to see this floor effect that you can see kind of along the bottom. The reason for that is because the Vineland expects that there will be an improvement or a progression in their development as these children age. But as we've seen with some of our Syngapians, their developmental milestone, their ability to meet developmental milestones kind of slows so that it can't keep up with what the Vineland is measuring. And so you see this sort of floor effect, which then means that it's difficult to see the differences between these individuals as they get closer and closer to the floor. So some of the takeaways from the Vineland is there are lower scores across the scales compared to the broader neurodevelopmental groups. There's a faster decline in scores across all of the ages, and there is a floor effect that limits that ability to detect any true differences between each of our Syngapians.
So then we went ahead and looked at, data from our clinic in the ENDD clinic. So I looked at the charts of 100 Syngapians who we had seen. In our entire sample, 87% had a autism range score on the CARS, so that's anything above a 30, with the mean score being 35.1. We found that 77% had an actual autism diagnosis, 59% reported challenging behaviors, 36% were receiving ABA, and 29% reported taking medication for behavior. So the chart review gave us good qualitative data on behavior, mostly through my histories and the histories of our occupational therapists. But in order to make sense of this data, I converted it to a numerical data by creating a behavior severity scale. The ratings go from 0 to 3 and really reflect intensity, frequency, disruption, and externalizing behaviors. So a 0 means there are no difficult behaviors whatsoever. A 1 represents mild behaviors. Think biting or scratching, no need for medication. A 2 represents moderate behaviors. Think aggression directed purposely at others, maybe use of a medication such as an SSRI or a stimulant. And a 3 represents very severe challenging behaviors, conduct or safety concerns, maybe medication management with an atypical. And we did find that myself and Kristen Cunningham, one of our other OTs, both looked at the data individually. We found we had pretty good inter-rater reliability between our behavioral data. So what you see here is a graph of the qualitative data when it looks, when we map age versus the behavior severity. And we found a gradual rise in the frequency of more severe behaviors as individuals get older. There's no statistically significant linear relationship that we could see thus far, but it does appear as though severity maybe starts to increase around age 5 or so, and then kind of plateaus and maybe peaks around age 12 and a half. So again, there's no statistically significant linear relationship. But we do see that severity kind of start to increase as kids hit that school age transition, and more work could be done to further investigate and potentially even validate the scale.
So speaking of that age, I think for where we start to see that behavior start to escalate is that it is when it appears when there are additional demands being placed on the child. So going back to thinking about what our negative behaviors are and what they are when they're present. So the high emotional reactivity, the tantrums, the meltdowns, self-injurious behavior, and just kind of their difficulty with engaging in and completing their day-to-day tasks. Some of these behaviors are going to impact their ability to engage in school, to engage in their self-care, to engage in play and grow and learn, as well as to engage in their social, the ability to engage in social situations with peers and or family members. So the way that occupational therapists will address this oftentimes is to present a just right challenge. The idea, so think about Goldilocks and the 3 bears, right? There are 3 different types of porridge: too hot, too cold, and just right. The goal of the just right challenge is to be able to set up the child for success. We want them to be able to do what it is that they set out to do, whether it's school, whether it's self-care, whether it's building relationships. We just want them to find success, but we also want to set them up for that. We also want to decrease the propensity for challenging behaviors. So the behaviors are going to impact the ways in which they are engaging with their task, engaging with their environment, engaging with their peers. So we want to be able to decrease the opportunity for them to have those behaviors. The just right challenge then is allowing us to set the correct expectation. That doesn't mean to make it too easy so that the child doesn't feel challenged, because then that child will not grow and will not develop the skills necessary to progress through their either their school or sort of life challenges. We also want to hold them accountable. So if we're asking them to do something, we are waiting for them to be able to accomplish that. But in order to do that, we want to give them the support that they need. The hard part with these behaviors, and a lot of the things that have been reported, is that caregivers are afraid to challenge their child because they're afraid of eliciting a behavior, or they're afraid of eliciting avoidant behavior, aggressive behavior, whatever it might be. So in terms of, life progression, we want to be able to challenge them just enough that they're able to still find success with support, so that they're able to continue to grow and learn as children do.
So in summary, behavior is complex, multifaceted. It changes across time and across contexts. We found on the CBCL that we have a pattern of increased reporting of behavioral challenges, especially with attention, thought, and social problems, and that increase in aggression and oppositionality that really seems to peak between ages 5 and 12. On the Vineland, we saw lower scores across all scales with a faster decline, but it's limited by the floor effect, so that ability to differentiate change in individuals kind of is diminished. And we found that age and behavioral severity, there's kind of an emerging pattern that starts to show a challenge in an increase in challenging behaviors around that kindergarten age. So next steps could be validation of the scale and using specifically the CBCL for pre or post intervention data, since that seemed to capture behavior possibly better than the Vineland, and can be used really from 1.5 until about age 18, and it has been used in other studies to look at pre and post data, so we can look for changes after an intervention. So again, we want to thank our whole ENDD team, and thank everyone for being here today.
Thank you very much.